You know that feeling when you wake up tired, even after a full night's sleep, when you push through your day running on empty, wondering where your energy went? Here's something most people don't know, that fatigue may actually be happening inside your cells. That's why I've been using anti-factor lipids powder from Nutritional Therapeutics for years. I don't go a day without it. It's based on over 20 years of research and a patented process called membrane lipid replacement, which actually repairs the damaged components of your cell membranes, restoring your cell's ability to produce energy the way they did when you were younger. Clinical studies show anti-factor can reduce fatigue by up to 40%. Just 1 or 2 scoops a day. Mix it in a smoothie like I do, sprinkle it on food, and you're giving your body the science of youthful energy. Anti-Factor Lipids Powder comes in 2 convenient sizes. For more information and to order, just call 800-982-9158, 800-982-9158, or go to antifactor.com. That's antifactor.com for Anti-Factor Lipids Powder. Welcome to today's Intelligent Medicine Podcast. I'm your host, Dr. Ronald Hoffman. It's our weekly opportunity to answer your questions. Questions come to questions@drhoffman.net. I'm with Leyla Muden, who's our resident nutritionist, and as usual, it's my pleasure to do this, one of the highlights of my week. And I must say, I must commend our audience because both on my radio program and in this forum, Dr. Hoffman it's drhoffman.
Questions@drhoffman.net.
Yeah, it changed. Questions@drhoffman.net is the destination for questions here. And then on my radio program, it's 877.
Oh, you have it.
I have it.
Yeah, you have it.
It's my radio program, right. And I'll just look that up. It's 877-26-8255. You call that number and you can record a question. And we got quite a few questions that we were able to air on my live program. Now, just a very a technical note. One of the reasons that we do that is because I do the program live.
Yeah.
On Saturdays from 12 to 2 Eastern time.
Mm-hmm.
But we have many affiliates. We actually have dozens and dozens of affiliates across the country. But through the miracles of modern radio technology, some stations take the live feed and they store it, and then they can air the program later. And what that means is I keep giving out that number, like call us. But the people hear it maybe at 10 p.m. Pacific time or something like that in one of our West Coast affiliates, and they can't call in live. So they have to call in and then to get an answer box, basically, where they can record a question.
Yeah.
So it enables us to take seemingly live questions with people's real voices on the air. And it creates a verisimilitude of a live program. But we do get live callers interspersed with that. People who call in from the local radio affiliates, or they listen online. Mm-hmm. They listen, and that's a good way to listen to stuff because, frankly, I mean, I travel all over the world, and sometimes I want like the local news from New York, and I just go online.
That's it.
And I could be in Lithuania, and I can listen to, in the afternoon, the morning show in New York, and find out what's happening in New York. So anyway, so you can listen online. You can listen if you have a local radio affiliate. All right, enough of that. We have a bunch of questions, but we have a little bit of
comments.
We have an article that you wanted to to talk about.
Yeah. It's about weight inclusive care.
Mm-hmm.
I belong to a dietetic practice group. One of a few. One is for integrative and functional nutrition dietitians, but also for nutrition entrepreneurs is one. And a very interesting article came out, and it was because of a topic that was done at FNCE. FNCE is the Food and Nutrition Conference Expo that is done every year by the Academy of Nutrition and Dietetics. And what they're talking about is weight inclusive care. How do we provide weight inclusive care while still respecting the client's autonomy? And there is a new word. It's a new word for me. The person who writes this article says something else I enjoyed learning from this presentation was about healthism. Healthism is the idea that a person's health is entirely that person's responsibility.
So just by virtue of using the word ism, it it's almost has the connotation of racism, sexism, anti-Semitism.
Yes,
is that it is inherently weight is
ism.
an attribute that is something that stratifies people in the intersectional mix.
Yes,
right, and it sounds like it's almost a little bit of an offshoot of DEI thought.
Yes,
diversity, equity, and inclusion, and
right.
like awareness that there are different categories of people that we discriminate against because of certain immutable characteristics.
Yeah.
But here's the thing. Healthism, it's not as immutable as the color of your skin.
Right.
Or your racial ancestry, that you are of Jewish ancestry or something like that, right? Mm-hmm. So that's where it gets a little dicey. But it seems to me what they're saying, and there's actually a point to be taken here.
Sure.
Is that the very last bastion of discrimination and permissible hate, jokes, approbation is against overweight people.
Yes.
Right?
Yes.
And partially because it is thought to be a moral flaw. But what are the 7 great sins? Well, one is gluttony.
Yeah.
Right? And so and another one is, I guess, gluttony is another one. What is like sedentary sloth. So sloth plus gluttony equals excess weight. So that takes care of 2.
Right.
Right.
Yeah.
Of the 7 deadly sins. So there is a certain approved, to this day, approved societal approbation against people who are overweight. So I guess, is it sort of like, when you're on a date and you want to initiate sex, you have to ask for permission. Like when you're a dietitian, when you have an encounter with a patient and you have to ask them permission to optimize their weight. Is that a little bit what the implication of this is?
Possibly.
Yeah.
Possibly, like not to go there. The advice is, and here's an example. They say, this is advice for dietitians. I am to say to the client, you have complete body autonomy. But of course,
right.
I think we can work toward your health goals with or without weight loss. I agree with that. That's fine too. But if weight loss at any cost is your primary focus, I am probably not the right fit. I disagree with that.
Yeah, right.
If everything is fine with their health and they want to lose a few stubborn pounds, I'm still in their corner.
Right.
I'm there to help them.
But the counter argument to that is we do have sometimes patients who are, quote, overweight.
Yes.
They're not happy with the way their body looks.
Right.
According to, Metropolitan Life Insurance scales or optimal BMI, they're heavier. And we assess them. We'll look at cholesterol. We'll look at their cardiovascular risk. We'll find that they have 0 coronary artery plaque. They have a great hemoglobin A1C. Their insulin is normal. We can't find a problem, a metabolic problem. Their thyroid is fine. They have good energy. They work out at the gym.
Yeah, their hormones are fine. There's nothing abnormal there.
They're very physically active, but they can't lose those pounds. Those are the most challenging patients.
Yes.
And I endeavor to reassure those patients that the weight loss
that they're healthy,
and that there should be some self-acceptance.
Yes.
And that there, frankly, are some barriers to ultimate weight loss.
Yeah.
There really are some people who are not constitutionally suited to get to that body image that we now put on a pedestal.
Right.
Okay.
Right. And then
my primary goal is to get people to be healthy.
Absolutely.
A secondary goal might be to achieve a cosmetic.
Exactly. And here's the wonderful thing that happens when you decide to get healthy. A nice little side effect to that is you're going to lose some pounds whether you want to or not.
Yeah.
It's going to happen.
Yeah.
It's going to happen.
Well, so an example of which is, by the way, these weight loss drugs. These weight,
Yeah.
I mean, they make the pounds peel up, but also other ancillary things happen. There's reduced inflammation. There's reduced cardiovascular risk. Blood pressure improves. Blood sugar improves. I mean, originally these were
Yes.
diabetic drugs. So there's a lot of consequences associated with weight loss, but there's a certain, I think, a plateau where there's diminishing returns for that person who is maybe 12 or 15 pounds overweight, who is metabolically healthy, and has been on the best possible diet. And already, see, give me a patient on a really crappy diet who isn't working out at all,
Yeah.
has triglycerides,
Or through the roof. Yeah.
and whose hemoglobin A1C is like 6.2.
Yeah.
I can turn that around. Yeah.
Absolutely.
So, this also, this is a related topic is the fat acceptance movement.
Yes.
And I think that this smacks a little bit of that.
Yeah.
And there is, like with Lizzo, who is a performer, who is, very overweight, and I think it's an encouraging role model. By the way, she dances amazingly.
Yeah.
And I've seen her dance in an entourage with, frankly, overweight dancers who are extremely lithe and extremely proficient performers. And I've actually gone to Broadway to see some musicals where they actually include, and this is part of inclusivity,
It is.
to include some overweight performers
Yeah.
who can dance. They are amazingly fit dancers. But the point is, should we, inadvertently in fat acceptance, accept an unhealthy state of affairs for people?
Right.
It's a quandary, because on the one hand, we don't want to put the onus on these people. But on the other hand, we do want to optimize their health. And we do have a health problem in America that's related to obesity. We can't ignore that.
And here are the health risks associated with not addressing the weight. What's going to happen to those dancers' knee joints in 20 years? They're going to be more arthritic than somebody who's carrying around somewhat less weight.
Yeah, I worry about that.
You almost can't argue that.
Yeah.
That something's going to happen.
No.
The wear and tear of all of that.
Yes.
So you have
an example of which is, like NFL linemen, like offensive linemen. They can be upwards of, 300 pounds. And, they're like sumo wrestlers, basically. Each time that, the ball is snapped, they collide and slam each other. And those guys generally don't live that long. There's not a lot of octogenarian or nonagenarian
now this
NFL
is an interesting
football
study.
linemen. Yeah.
Wow, that's an interesting
right?
study.
Because maybe Tom Brady could live to be, 95.
Yeah.
Because that guy really took superb care of himself.
It is.
And
Very
it's a
disciplined.
different position. I mean, yes, you have to be big. Yes, you have to be strong, but you also have to be really nimble and fast. And he recognized that. And I think one of the keys to his success and longevity in football was his very exquisite, conditioning regimen and diet regimen,
True.
But
Okay. Yeah, well, I thought this would be an interesting topic to start with today, and there you have it now.
Yeah, I mean, I think we need a nuanced approach to this.
We do. We do.
Thanks for teeing up that discussion.
Are you ready to experience the future of digestive wellness with Dr. Ohhira's new and revolutionary postbiotic fermented food concentrate? Capsule-free and in individual sachet packets that harness the power of 5 years of fermentation and over 500 concentrated bioactive postbiotics. Dr. Ohhira's postbiotic fermented food concentrate is a nutrient-dense paste designed to supercharge your digestive health, aid in nutrient absorption, and support whole body immune wellness. Each sachet packet delivers a potent blend of fermented paste and prebiotics which serve as fuel for your body's own unique gut microbiome. This concentrate supports your entire digestive tract, does not need refrigeration, non-GMO, dairy, and gluten-free. Dr. Ohhira's postbiotic fermented food concentrate. It is the ultimate embodiment of traditional Japanese fermented craftsmanship, designed for those who seek the highest concentration of nature's restorative power in every serving. Ask your natural products retailer for it today or online at essentialformulas.com.
Okay, and we also invite comments in addition to questions on Q&A with Leyla. We have a couple of comments,
We
right?
have a couple of comments, Dr. Hoffman, on your article, New Disease Trends Highlight Medicine's Biggest Failures. What comes from?
By the way, just
Yeah.
to summarize the article, the two biggest failures that we see in terms of America's health picture, one is the striking incidence of cancers in people under 50.
Yeah.
Is although we are coming up with better cures for cancer, not, many cancers we're not making that much progress, but certain cancers we're making some progress finally. Not the, quote, cure for cancer, because it's going to be a multiplicity of cures for multiplicity of cancers.
Yeah.
But we are making progress. But when it comes to people developing cancer, we're seeing an alarming uptick in cancer in young people. And we saw just such an instance of that. We saw a young man who came in and, he said he was feeling a little tired. He was a bodybuilder, a guy who really looked like a muscle man. And I said, let's do some blood tests. We found he was anemic. And, there's no reason for you to be anemic. You're not on a vegan diet. You need a colonoscopy. Found out he had colon cancer like 36 or something like that. And so we are seeing more of that. And on the other end of the life cycle, we're seeing declines in lifespan.
Yes.
Because America's not making progress. Other countries are making progress. The average lifespan is declining in America. But also a decline in health span is the time that people spend unhealthy, sick, loss of mobility, loss of cognitive, loss of quality of life has increased.
Yeah.
So and more people being medicalized. There's a lot more polypharmacy.
Yes.
Which has quality of life implications. So in that way, medicine is having some spectacular successes, but in some big areas, we're failing. So anyway, people comment on that.
So we've got two comments here, one from Dr. Lena and the other from Charles. I'll just briefly, thank you for your insight of lifestyle and environmental factors with regards to plausible causes of cancer. In the article, do you mention the novel mRNA gene therapy, the vaccine, as a plausible factor? Do you think it could be possible that this new drug therapy is a factor? How do we know that it isn't when there are no toxicology studies completed prior to injecting millions? And Charles writes, I'm astonished and saddened. Are you too baffled and alarmed at exploding cancer rates? Your survey of causes was safe and effective, but of course avoided the real cause. The real cause is also safe and effective.
Quote, so safe and effective is, it's actually, I think that's the title of a documentary that's like an anti-vaccine documentary, safe and effective. So, okay, so both of them are, and I'm pleased that a physician is part of our audience. I'm really glad to have health professionals listen to this. And I think, one of the ways that I got into this is I was listening to tapes and radio programs. I listened to Carlton Fredericks. I listened to Dr. Atkins. And, this is a learning experience for me. So, if you're a young aspiring practitioner or a veteran practitioner and you listen to this, I hope this brings some quality to your information flow. Okay, so when it comes to the vaccine as the cause of the cancer, it's a little bit hard to attribute the rise in youth cancer to the vaccine because the vaccine is relatively recent.
Yes.
And, I've seen some of these inflammatory postings on Twitter about turbo cancer. Doctors report turbo cancer.
Turbo cancer.
And I don't know. Maybe I'm not an oncologist. I don't know. I'm not seeing that. But maybe oncologists are seeing like a rise in very rapidly disseminated cancers. But studies have not picked that up. But the biological plausibility of that contention is not that great, given that cancer takes a relatively long time to develop. So the cancers that people are developing at 36 may have had their roots in their 20s,
Yes.
or even before. So,
right.
So I think it's about crappy diet, toxic environment, that kind of stuff.
Yeah.
Maybe sedentary lifestyle contributes to that to a certain extent.
Toxic emotions, all
kinds of
emotions.
And I mentioned that,
trauma is a big part of that too.
Stress is rampant among young people, and there is actually a stress cancer connection, but it's not the end all and be all. I think it's going to be a multiplicity of factors. Is the vaccine implicated? I don't know. To be seen. I think the vaccine has a wealth of side effects. I will point out, though, that if this guy, he said he was going to unsubscribe because we didn't. Yeah. Okay. Cool. Well, we're starting to lose you, but I think you misread me if you think that I am oblivious to concerns about the vaccine. And, as we'll see later, because we have a question about another vaccine, I am not per se anti-vaccine. However, on my radio program this weekend, I took to task one of my colleagues who actually I interviewed on the radio. She had a guest essay in the New York Times. Her name is Danielle Ofri. She's a primary care doctor working out of Bellevue here in New York. It's one of the places I trained at. She wrote a guest essay entitled, "My patients used to be gung-ho about the COVID vaccine. What changed?" And she appears to be puzzled because she says, all these patients, they took the first two vaccines and now they don't want to take the booster. And, what she's saying is they don't really understand. When she queries them, why don't they want the booster? They don't really have an answer. And so she then says, as like a benign, I think somewhat paternalistic physician, although she's a woman, women can still be paternalistic.
Sure. Yeah.
Maybe they're maternalistic, but I think maternal is more benign than paternal.
Yes.
In this sense.
Yeah.
She says, well, let me talk to these poor benighted people and engage them in conversation and question their irrational resistance to the booster. And she concludes, she goes, here they are, one after another, rejecting a medical intervention that most have safely received before that substantially improves outcomes. And they can't really articulate a specific reason even to themselves. Well, this is wrong. This is wrong. Is the people who aren't taking the vaccines, and by the way, I think like 21% of Americans have taken the booster.
Yes.
And many of them, I think, maybe older people who are frankly kind of scared.
Yeah.
And the rate among children where they're still recommending the vaccine is infinitesimally low. Parents don't want their kids to get the booster. And here's the problem. The problem is that people are aware that it doesn't really provide any, if at all, protection.
Yeah.
Especially if you've already had COVID, which the vast majority of us already have had.
Yes.
I've had it twice. You've had it once. There are other people who may have had, unbeknownst to have had it because they don't bother to test themselves anymore.
Yes.
Some people may have had a subclinical thing. We can ascertain with a blood test whether they required natural immunity. So new study out of Austria, boosters do not work in people who have had COVID. Now, in people who've not had COVID, that's another question. If you are the rare person, maybe there's like single-digit percentage of people who've never had COVID.
Yeah.
Maybe a booster, maybe, but that hasn't really been tested because it's such a rare case.
Yeah.
There's so few people who, and so what they found is the authors report all-cause death is lower in boosted groups. Okay, but that may be, it's very modestly lower, and that may be what's called the healthy vaccine bias, vaccinee bias. In other words, people who seek that out, they have healthier behaviors in general. They're better educated. They're probably,
they take better
maybe
care
they
of
take
themselves.
vitamins, they eat a better diet. So but they finally conclude, we did not observe a significant vaccine effect of a fourth vaccine dose for COVID-19 deaths during a time with already very low absolute risk for this outcome. And in fact, whether or not people took the vaccine, no individual younger than 40 died due to COVID-19 in this study in Austria. So big study. Another study from Qatar suggests the natural immunity confers a very strong and lasting protection against severe COVID with no evidence of waning immunity. And the problem with the vaccine is that in the best case studies, it shows that it can slightly increase your antibodies, which may equate to real world resistance to COVID or bad outcomes from COVID. But that wanes very quickly within weeks.
Yeah.
And natural immunity is more durable. So, and then finally, there's also a review from Peter McCullough already. He's anti-vaccine, but it's a very well articulated review. And he says basically three things. He says, first of all, the trials were inadequate. They rushed this into production, and the findings were even omitted. There's some missing data. Some of the findings were misrepresented when they got the emergency use authorization for the vaccines because of the fear and apprehension over COVID, which may have been warranted, because we didn't know what we were dealing with.
Yeah.
But he says, second point, it was only after the emergency use authorization that the serious biological consequences, I'm quoting, of rushing the trials became evident, with numerous cardiovascular, neurological, reproductive, hematological, malignant, and autoimmune serious adverse events were identified and published in the peer-reviewed medical literature.
Yeah.
So this is real. There's a lot of side effects with these vaccines. And he also is concerned that the more boosted you are, the more likely you are to have a reaction. And that's quite possible, although it needs to be further studied.
Yeah.
And finally, he says that for the vast majority of adults under the age of 50, the perceived benefits of the mRNA boosters are profoundly outweighed by their potential disabling and life-threatening harms. So he is calling for a global moratorium on
Good for him.
mRNA products until all relevant questions pertaining to causality and also he's also talking about production problems.
Yeah.
I mean, how can you produce something, even an airplane, we see the doors are blowing off of airplanes.
737.
But if you want to create like hundreds of millions of vaccines, you think the quality control was perfect on those vaccines? Do you also think that in every venue where you got them, they were properly transported and stored? And for those of you who worry about that you took the vaccine and you wish you hadn't, maybe you got a dud vaccine.
Yeah.
So,
Blessing in disguise.
because I got my 2 shots, and then within like 2-3 months, I got COVID fairly severely. I mean, like I was felt sick as a dog, but I wasn't in a life-threatening situation. So, would I have been worse? I mean, some people would contend that, but then I said, I tried to kind of do a little mind switch. I said, I am so miserable. I said, thank God I'm getting natural immunity. I'm getting sick. So it's like, what doesn't kill you makes you stronger.
Exactly.
Right.
Exactly.
So anyway,
Wow.
so this is to push back against people who since this guy is unsubscribed and he's not listening to us anymore because he's a pout because we didn't, we didn't mention his favorite subject, which is vaccines. Lest we, and at the risk of turning off some people, because some people will say, how can you're a responsible doctor and you have a lot of outreach to people. How can you possibly impugn the vaccines, which are so much our public safety measure against COVID? It's like, no, I got to be balanced and real in my assessment about this.
Absolutely. So, thank you for your comments. Dr. Leyla and Charles. Charles, we're sorry to see you go.
We're sorry to see you go.
Okay. All right.
And, you'll be missing out, but
it
is what it is.
Okay.
What Abraham Lincoln used to say. You can please some of the people all of the time, but not all the people all of the time.
Right.
Whatever he said. The thing.
Yeah.
You know the thing.
Yeah, exactly. Time for another question, or are we about the end of
we're about
part
the
one?
end of the line for part 1. So we'll have more time in part 2 to answer some of your questions. And questions come to questions@drhoffman.net. Today, I'm with Leyla Muden. It's our weekly Q&A with Leyla. And this is the Intelligent Medicine Podcast.